Hi, everyone, and welcome to our webinar for today, Funding Mechanisms for Preventative Health Apps in Primary Care. I think we have a really interesting and exciting webinar, and I'm really, so I think I'll get us started. Before we dive in, just a little bit of housekeeping. We will be recording this webinar just as an FYI, and I think we have already begun recording, including probably a certain amount of my eating my toast 15 minutes ahead of time, which we'll edit out at the end. Um, but we're also going to have some questions and answers at the end. And if you do have a question that occurs to you during the presentation, please use the Q&A button at the bottom of your Zoom screen and enter it there. And then if time, we will review and answer questions. And if there isn't time, they'll be posted on the AIDH website. And I also just want to begin by acknowledging traditional owners of the unceded lands of the University of Melbourne and AIDH, the Wurundjeri Woi-wurrung and Boonwurrung peoples. And I want to pay respect to elders past, present, and future, and any that may be joining our webinar today, and also acknowledge particularly the importance to Indigenous knowledge of technology and in the academy. And just to introduce myself, my name is Portia Cornell. I am a senior research fellow and a health economist at the Center for Digital Transformation of Health at the University of Melbourne. And I will also turn it over to my colleagues, Carol and Debbie, to introduce themselves.
Hi, everyone. Thank you for joining us today. I'm Carol Kenny Sarasa. I'm the Senior Policy Advisor at AIDH, Australasian Institute of Digital Health. And I'd like to acknowledge behind the scenes my colleague, Laura Kumak, who is doing the project management on this project. I would like to acknowledge that this project is funded under the Health Peak and Advisory Bodies Program Community Grant Funding from the Australian Government Department of Health, Disability and Aging.
Hi, I'm Dr. Debbie Passy. I work with Portia at the Center for Digital Transformation of Health, and I am the implementation science specialist on our team. Happy to be here.
And I will just start by giving us a brief overview of the agenda today. We're going to start with a bit of background, and Carol will give you an overview of the motivations behind this project and some of our sort of assumptions about the current state of funding for preventative health apps, and also give you a little bit of a sneak preview of our high-level findings. Debbie and I will go into a little bit of depth about some of the evidence that we discovered in our environmental scans. And we will also discuss the group's conclusions around potential funding options. Finally, we are really excited to introduce a survey, and we'll wrap it up with Q&A and a bit on our next steps.
Thank you very much, Portia. So this project, so just to acknowledge that there is a webpage on the AIDH website dedicated to the project where you see more detailed background and where we are going to also post updates on the project as we hit different milestones. And the content of this webinar today is the content of a report we have put together and is going to be published in the next few days. In terms of the broader context, we are looking at ways of supporting adoption of digital health technologies. For this project specifically, we are going to look at the funding mechanisms that support health practitioners who are supporting and monitoring consumers who are using preventative health apps. We are going to look at identifying different types of apps that present a preventative benefit. We are looking at what are the funding options that exist. We have looked at Australia and different examples overseas. And we are going to look at doing a cost modeling of those options. We're going to choose two potentially at the end of this stakeholder engagement and look at their financial impact. So we want to know if we started to fund health practitioners, what could be the impact on health budget overall. Quick high-level timeline. We started on the 1st of July and we are going until the end of June. So 12 months for this project. Up until now, we dedicated the time to set up of the project. Always takes longer than anyone anticipates. And we've conducted the desktop research and the evidence scan. The University of Melbourne Centre for Digital Transformation of Health is our partner, not in crime, in research for this project. We are now in the phase of the consultation and stakeholder engagement phase of this project, and this is why we have this webinar today, and we are launching the survey, which we have mentioned before. And after that phase that we anticipate is going to conclude around February or March, will be the analysis from the survey responses and going into the meat of the cost modeling. In terms of scope and alignment, there will be more details on that in the report if you want to have a more detailed presentation. But in a nutshell, we are working within the objectives of the National Preventative Health Strategy 2021-2030. We are looking at apps where the data is monitored by a health practitioner in primary care. The apps would have to be vetted, at least vetted by the Health Apps Assessment Framework. Caveat, it doesn't exist yet. So that refers to another project that AIDH conducted last year. All information is available on our website, and I'm sure the link will pop up in a second if you want to know more about this framework. But it's an important assumption of this project is that we have a strong way of vetting apps. Apps will have to meet some interoperability criteria. And important information, an app doesn't have to be approved by the TGA to be included or excluded from this project. However, we note that apps that are preventative are likely to meet the definition of software as a medical device and therefore fall within regulation of TGA and should be approved by TGA before supply or availability in Australia. Out of scope, but very important for this project, we are not going to look at consumers' reimbursements. These are the payments that are made to consumers, or so consumers could have access to the apps for free in case of apps with subscriptions or a fee. It's not looking either at other costs related to the use of apps, costs around owning a device, smartphone or tablet, and the cost of an internet subscription or access to data. Another thing that we are not looking at, but we think would be important to explore funding mechanisms more broadly, is what would be the potential role of private health insurers. So we are focusing on funding mechanisms that would come from the federal government.
And so I'm gonna thank you, Carol, and I'm gonna jump in here just to talk a little bit about although we're not going to talk about consumer reimbursement, we are going to talk about this problem specifically from the perspective of a consumer's journey or a patient journey. And just as an example of current use, I always think it's often helpful as researchers when we can bring some depth and texture to our research from personal experience. So I can tell you a little bit about my husband, Andrew, who is a type 2 diabetic, is sort of in the midst of this journey. He recently started using continuous glucose monitoring to monitor his blood sugar and his diabetes. And so, he's kind of in those first two steps where his GP recommended that he try this out, and he did and liked it very much. But recently has had some issues with tight control and some neuropathy. And the way things are currently set up, he's in a situation where in order to bring data from his glucose monitor to his GP, the other day he was literally printing out graphs from his app on our home printer and then bringing them into an appointment. And the perspective of this particular, so I think that sort of, gives us some understanding of why we want to do this work, where it's like, certainly there must be a better way to do this. And we know that there are better ways. And how the question is, how can reimbursement best support that so that it's not just a matter of the patient being responsible for creating an appointment, that might not even be necessary to have an appointment, but a clinician can sort of monitor those data and support the patient asynchronously.
You're on mute. Thank you very much, Portia. So high level or summary of the findings of the first work we've done. We didn't find a silver bullet. We didn't find a funding mechanism that we could just take an example of and implement in Australia and scale. So we're gonna keep working. We could have stayed there, but no, we're gonna keep working. We didn't find that silver bullet. We are seeing emerging 3 practical funding options. One, and I will get into more details around each of those options later in the webinar. First option would be to use targeted Medicare benefit schedule items, MBS items. Another option would be to look at monthly payments linked to my Medicare enrollment. And the third one would be to explore the opportunity of a national commissioning pathway. It's important to note at this stage that it is possible that a one-size-fits-all funding may not be appropriate, and we may need a mix of those funding arrangements to reflect really the diversity of preventative hubs. And that diversity means different levels, they have different purposes, they have different ways of working, which means it requires a different type of involvement in terms of frequency and depth from the health practitioner in their monitoring role, which means that maybe one way of paying is actually would not be suitable for everything. Something I would like to note at this stage as well is we are not looking at outcome-based payments at this stage, but it's definitely something that we would like to see later on. We acknowledge that at this stage, the way of recording outcomes is probably not ripe enough to be able to implement that kind of funding, but definitely an interesting avenue for further exploration. Yeah, and the last thing, sorry, implementation choices are critical. I will come back to this. Funding mechanisms are not neutral, and so we need to look at the impact on different aspects of those funding mechanisms. Thank you.
Thanks, Carol. So I think that it's very helpful to have given given you spoilers about where this is all headed, as Debbie and I give you an overview of what we found with our evidence scan. And before we dive into what we found, I sort of want to situate, what this scan is so you can understand the context of, what evidence we're able to present. So I think of evidence scan and literature review kind of sit on a continuum where all the way at one end you have like a journal club with a single article, and all the way at the other end of intensity is something like an official Cochrane style systematic review or meta-analysis of RCTs. And this is somewhere in the middle, where given the resources and time that we did what we call a rapid literature review, meaning that don't think of this as an exhaustive or representative, even necessarily representative search, but we tried to choose some illustrative examples of different country contexts, including Australia, and some varied examples of where preventative health apps are being used and the cost effectiveness when it's reported. And just some particular ways we tried to narrow and focus the search to really make it useful. Since 2015, since a lot of these apps didn't exist before then, we decided to zero in on chronic disease management and preventive disease prevention and management, and particularly asthma, cardiovascular disease, COPD, and diabetes were our focuses, because otherwise it just would have been too big of a question. And then I think the key that really narrowed down the applicable studies were that as we went through, we excluded any study that did not include in the intervention some aspect of asynchronous monitoring, where somewhere along the line, a physician or allied health or other kind of hospital staff or nurse had to be monitoring or in a position to monitor data that was being transmitted by the app. And it turned out that actually eliminated a lot of our mHealth interventions. But since that's the focus of our policy question, that's really what the focus of our search was.
So this is sort of a breakdown of the study types. We found 19 studies. 8 of those were randomized trials. There's a prospective observational study. Among the 19 studies, there were 11 studies with economic models. So I want to note there's a little overlap where we found RCTs that reported an economic model. And then we included 4 systematic reviews and meta-analyses. The countries where the studies were from represent some of the globe, not everything. We did have 1 study from Australia and 1 from New Zealand as well. Thanks. And then the types of apps and features, they kind of more broadly fell into categories of apps for monitoring. So, for example, an app that allows consumers to log in and monitor their symptoms, such as chest pain or shortness of breath. There are apps for management. So maybe an app that helps consumers manage their medications, such as dosing, schedules, and potential interactions. And then there's apps for behavior change. And these are apps that have, maybe encourage and monitor physical activities, such as counting your steps or your exercise routines, and also contain educational resources. But more often, the apps combined sort of a mix of all these different features.
And one of the things that we really focused on with trying to pull information from the studies that we reviewed was really understanding, who's monitoring the data, how are they doing it, and at what intervals. And broadly speaking, data monitoring, we were able to kind of classify it into 3 types. So manual review, one example of an app would be something called the HeartMan app, and it was a mobile app to monitor heart rate or blood pressure. By manual review, simply meaning that only a person is reviewing these data. It's not being reviewed by an algorithm. And that kind of does leave it open to simply in a dashboard that's passively available, and a clinician can view the dashboard, as often as they feel is needed, to having clinical staff set up to look at those data every single day. And then the next type that we sort of classified things as is what we called algorithm surveillance, or sort of automated monitoring. And the idea here is that there is some kind of algorithm keeping track of the data that are being entered or transmitted by the app, and then it sends an alert to a clinician when those data reach some kind of threshold. So an example here is in a study we reviewed from a regional health service in Victoria. Patients would enter their upper and lower limits to their blood pressure, pulse rate, or blood glucose. And then there was a program that would view those data and then send an alert to nurses on staff. And then in response to the alert, nurses would make contact with the patient. And that's sort of like an example of a hybrid system, because there's both an algorithm surveying the data and nurses who are also kind of reviewing the data and then responding to the patient. So the vast majority had had kind of both of these. As soon as there's a platform monitoring the data, there's not a lot of additional cost involved to having some kind of algorithm or alert system as clinical decision support to help understand, is this something that should um, uh, prompt a clinician intervention? And just from our perspective, it seems like probably with advancements in AI and machine learning, those algorithms are only likely to get more helpful and more accurate. And this is just to kind of give you a sense of some of the um, trade-offs between a more passive approach of just alert-based monitoring. Alert-based monitoring might be more useful if a patient is generally stable and doesn't necessarily need the intensiveness of having staff review their data every single day. It's also potentially more cost-effective if a clinician has a really large panel of patients that they're including in their monitoring program. And alert-based monitoring, the infrastructure would be more set up to on-call, more conducive to on-call coverage. On the other hand, there are advantages to more intensive monitoring, particularly if there is a class of patient who really needs a high touch, if they're particularly at high risk, and also if there's like an educational component, maybe particularly early on in a monitoring program, or having um, a clinician or a nurse or allied health person, not just reviewing the data, but responding to messages or concerns that are being entered into the app. There's kind of a place for all of these different approaches.
So looking at the clinical effectiveness across the conditions, asthma management showed strong results in a meta-analysis with significant reductions in exacerbations, better medication adherence, and less antibiotic use. For diabetes, the most consistent clinical benefits emerged in that management model, where the three mobile interventions demonstrated significant improvements in glycemic control. And those programs typically combined blood glucose monitoring with a multidisciplinary clinical team and patient education. The COPD studies had mixed results. So there was some prevention of acute hospitalizations, but other studies did not find any difference. And then for cardiovascular disease, there was a notable app for detecting AFib, and that showed effectiveness with heart failure management. And they found the potential to prevent 60 strokes per 10,000 elderly users over the remaining lifetime. So I think the results are promising, even though it is not a strong evidence base at this time.
And then when it came to the economic findings, a lot of the studies didn't include an economic analysis with their clinical effectiveness study, but some did. And this was tricky. In many cases, apps can be effective, but not necessarily cost effective. Some of the studies actually demonstrated cost savings, although that's a little bit of the holy grail with an intervention like this. And a lot of them looked at QALYs, but we also had several sort of cost consequence or cost outcome studies that looked at particular outcome, cost per particular outcomes like averted hospitalizations, averted adverse events, or cost for improved medication management. Some examples of those studies. I think it was spotty enough that it's difficult to make any kind of blanket statements from our evidence about the overall cost effectiveness just because there's just too much variation across the studies. But I think for examples, there's an asthma intervention in China that showed really clear cost savings in medical costs. One of the reasons is that asthma exacerbations are one of the primary causes of ED presentation and unplanned hospitalizations. So targeting chronic diseases that have a lot of unplanned or an emergency care associated with escalation might be something to think about. There was an app for managing COPD and asthma that had cost savings driven by better medication use, particularly some of the asthma apps that aren't just about monitoring for worsening of a condition, but were actually designed to give the user feedback on whether they were using their nebulizer or their inhaler correctly. So it was not just about monitoring symptoms, but about actual improvement of medication administration. And then there's an NHS study of something called COPD Predict that added about 238 pounds in costs at a gain of 0.02 qualities. So a really strong cost effectiveness ratio of about 12,000 pounds incremental costs per additional quality adjusted life year gained. And a lot of that, again, COPD exacerbations are a big source of unplanned hospitalizations for people in that chronic disease group. And so being able to manage those conditions, reduce those hospitalizations um, from their chronic condition, and also just improving general management and quality of life led to a better cost effectiveness. And I don't want to spend too much time going through every single study that we found. But again, just to give you kind of a general sense of when there were cost savings or cost effectiveness, where those numbers came from. Um, uh, Diabetes interventions, often there's a lot of gain to be had from better HbA1c control, better blood sugar control. We looked at one Australian study that of a remote patient monitoring program in a rural health service that demonstrated substantial savings, again, from those reduced unplanned hospitalizations. And then Debbie mentioned this particular atrial fibrillation detection. So not only is it really effective at preventing strokes, but it was really cost effective, did not cost much, and led to a tremendous amount of gain from stroke prevention. So keeping all that in mind, here's our kind of grain of salt disclaimer. Like I said before, we weren't able to do a big systematic review or meta-analysis because there are just too many different kinds of apps and too many different kinds of interventions. And I think particularly one thing I just want a note of caution that I wanted to add. I think folks are probably most are probably aware of the idea of publication bias, right? Where studies are more likely to get published if they have that statistically significant p-value. But there's not just a publication bias, there's also a particular bias in what are the RCTs that get done at all. And only the most promising technologies are the ones that really seem like a good avenue for investment are going to have a big, expensive clinical effectiveness study done on them. And so I think that raises the question of what level of evidence should be required before it's going to be reimbursed. Null findings are not necessarily highlighted in abstract review. And again, I think it's important to keep in mind that data monitoring is just one aspect of these interventions that often include care planning and care coordination and communication from the team.
Thank you.
And I'll turn it over to Carol to discuss a little more in depth our funding models.
Thank you, Portia. So the first thing we looked at is how is primary care funded in Australia and how digital health is funded in Australia. And no surprise here, both are quite fragmented. So in terms of primary care, again, this is detailed in the report, and I'm not telling you anything that you already know. In terms of primary care, it's mostly funded through the federal government and out-of-pocket costs for consumers. Looking at digital health and especially remote monitoring, that's especially funded through hospital-based virtual care. There are also a limited number of MBS items around telehealth, and for remote monitoring, 2 items linked to cardiac devices. And then we've got, as you know, the commissioning and the pilots and more out-of-pocket costs. Internationally, again, fragmented, different options. It's always hard to compare funding from one country to another because the systems are so different. But yeah, we didn't find the one silver bullet there either. We note that in terms of apps, we see a focus more on the consumer side. So having those apps funded as if it was medication, a bit like medication on the PBS, and less focus on the clinician monitoring time. If we were to choose one, it looks like fee for service is the most common option. Thank you, Portia. So we talked about what is the current state, and we projecting ourselves into a future state where it is easy for the clinician and the consumer together to choose an app that is going to be suitable, where they both have access to the data, where the clinician can upload notes to the consumer's record and to My Health record, and the clinician is paid for that review time without having to organize a consult. And potentially, we hope that we can actually avoid consults, whether face-to-face or via telehealth, when everything is going well, and that consults are only when it is clinically required to have that consult. So I mentioned earlier, we are seeing three main options based on what we've seen is working in Australia. Again, reiterating that to cater for the diversity of preventative health apps, we may need to have a mixed approach to funding mechanisms. So if we look at the first one, targeted MBS items, so what we are thinking is that those items could be based on the type of measurement rather than on the type of app. So a type of measurement. So depending on what is tracked by the app, whether it's heart rate, blood pressure, glucose, sleep quality, breathing. And in that case, the review and the depth of the frequency would be anchored in clinical guidelines. So that would depend on what the measurement is, but also depending on the condition. We've indicated what we think is the most obvious advantage and then the most obvious downside of each option. So the most obvious advantage is using an ABS item is something that is already known by doctors. We've got the system in place, and we could leverage already existing items, both for monitoring and items linked to chronic condition management. The downside is, well, there are heaps of MBS items already, and we want to avoid, ideally, that proliferation and adding complexity. And we are acknowledging that this option has the complexity of potentially many different items to cover all the different scenarios. Potentially as well, to start with, it could be just limited to people who are already on that chronic management plan. The second option that we are seeing is something more along the line of monthly payments. We would probably link that to my Medicare enrollment, so which is an option available to consumers with a chronic condition. The way we see it, those monthly payments would be tiered and per patient, and those monthly amount would be paid, doesn't have to be paid monthly, could be paid annually or quarterly, but the idea is to have a monthly average with a higher first month for setup, induction, and education at inception. The idea of tiers is because we are acknowledging the complexity, the different complexity depending on the condition and depending on the app. an advantage of the monthly payment is that it supports continuity of care. You continue seeing the same practitioner that you've been seeing. It's potentially reduces administrative burden, as you don't have to claim every time you are reviewing. On the downside, it is a model that is in effect a capitation model, and it has been observed, not by us, it has been observed that capitation to lead to underservicing of some cohorts, or also it could limit access when sometimes practitioners have in their panel the easiest, sorry to use that term, the less time-consuming patients, and there's a risk that people with more complex conditions could be excluded. The third option would be national commissioning, which is where the federal government would be commissioning the work from one entity to provide that service, and would be a national program consumers can have access to. Currently, we just had the announcement of the digital mental health services that's going to be run by St. Vincent's and starting in January. So that's the kind of examples we could be looking at. In terms of advantage, it's in terms of rollout and equity, we have a national program that is working straight away. And there are precedents, there are plenty of examples of that existing, rather in digital health or otherwise. On the downside, we introduce a parallel access system. And so there's a risk of fragmentation of care. We lose that continuity of care unless we can, and can only be mitigated if we have strong information sharing between that national program and the usual health practitioner of the person. It is also likely that such a program would be condition-based, so more fragmentation, and people with multiple conditions would be split between different programs, which is already happening. In terms of the implementation considerations, so I quickly mentioned it earlier, funding mechanisms are not neutral. And I think I tried to make that visible in the last 3 slides, that depending on the options we choose, it actually has an impact on different aspects, including equity and access. The way we fund it actually has a direct impact on the ability of people accessing a service. So it's extremely important to take that into consideration. We need to look at the time variability, and this is where the idea of the mix comes into consideration. Maybe that one size fits all might not be appropriate. The question of continuity of care is very, very important. The clinical appropriateness. We want funding mechanisms that are going to support and enable care, not that is going to put a constraint around this care. The question of the administrative burden. I think we have health practitioners on the line. I don't think anyone would put their hand up for more admin work. And we have also the question of the cost to the practitioner. The provider here is a health practitioner. How do we cover the cost of them having the infrastructure to help with that monitoring? Thank you, Portia.
So I think my colleagues are humoring me and allowing me to put this graph up here. But I think the economists in the webinar will enjoy it, and hopefully everyone else will find it encourages a useful way of thinking about the problem, where if we think about inputs and spending on healthcare in terms of what we economists like to call the production possibility frontier, the idea generally is that the shape of this curve, this curve is shaped this way because with the first, few dollars or a few $1 million that you spend on healthcare, you get really big gains as long as you're spending them in the right place. And then with each, the marginal gains in better outcomes or benefit to patients is a little bit less with the more dollars that you spend. And the A on this production frontier is probably where Australia is now, and sort of an early, and it's kind of where most of our research also sits in terms of, there's not a whole lot being invested in preventative health apps, particularly in primary care. Probably where they are being used, and in the research context is those where they're going to be most effective. But certainly we're not getting the maximum effectiveness. And then C is the point on the production frontier where for every additional dollar that's being spent on healthcare, we're getting the maximum amount of benefit. And this is kind of where Australia is trying to spend its healthcare dollars. And that's why MBS is set up the way it is, as well as the pharmaceutical benefit scheme, with cost effectiveness being a primary consideration, but also alongside equity. The problem is what we don't know, which is, how do we design a system so that we get to C and not F or D, where we're spending more money, but not necessarily for the maximum amount of potential benefit. And so that's where we really want to try and do this carefully, and make the careful assumptions and fill in our gaps in knowledge. So some of the gaps in knowledge that we're left with after our evidence review, I've kind of tried to frame in terms of, the PICO framework for health technology assessment. So first, the population. Who should be using these apps? What limitations should be placed on the chronic conditions or potential chronic conditions that could develop? And what are the requirements going to be for an eligible app? What level of evidence? And then in terms of intervention, what we really don't know is going to be the demand and supply response, right? So inevitably, with the introduction of a new reimbursement scheme, it's going to change provider behavior. But trying to estimate the response to that is very difficult when it's a brand new country context and a brand new scheme, right? So how many clinicians would take advantage of this who don't currently use preventative health apps at all? How many patients would be interested if their clinician offered it to them, or how many patients would bring this, how many consumers would bring this to their doctor or their allied care provider? And then what are the intended consequences, but also the unintended consequences of potential, extra use? And then what's the price? So in our model, we'll probably pick a price, but we don't necessarily know what's the optimal reimbursement amount, whether a monthly or a fee for service. Do we peg it to standard visits, or is there some other way to calculate a price that will encourage the most effective level of use? And finally, outcomes. So there are a lot of limitations. There are a lot of apps out there that don't currently have RCT evidence behind that app or intervention specifically. There's if I was designing the ideal study, I would want to design an RCT in which we had a mobile app intervention with asynchronous monitoring, and then the exact same intervention to compare it with everything else included, just without the asynchronous monitoring. But that's almost never the study that's being done, right? It's a multifactorial complex intervention compared to usual care. And the single thing that's varied is not necessarily going to be the data monitoring. And then there's really a lack of evidence about long-term prevention, which I think is fundamentally, what the Productivity Commission is interested in. And when we're talking about preventative apps, and as a country, I think is an ideal thing to focus on, but it requires the kind of study that looks at people's outcomes over decades, years, if not decades. And those studies are very rare.
Thank you, Portia. Yeah, definitely. When we started this project, by the way, we knew that it was a risk that the evidence wouldn't be available. So if there are funders on the call who would like to fund the research, please contact Portia. So we are running on time, so I'm very happy that we're going to be able to play the video. If someone has the hand and can play the video, please.
Health apps can help you stay healthier, tracking your fitness, managing chronic conditions, or catching problems early. But there's a gap. Most apps aren't connected to your healthcare providers, so you're often left to figure them out alone. We're researching how to change that. By understanding what matters to both patients and healthcare providers, we can help create funding models that make preventative care more accessible. If you use health apps or are interested in preventative health, we want to hear from you. Your experience can help shape a healthcare system that truly supports prevention. Share your views in our survey and help us build a system where prevention is properly valued and supported.
Thank
Health apps
you.
can help.
Oh, no, not again. I mean, it was great, but I wouldn't watch it again. You will see this video and a few others in our promos in the weeks to come. So here it is, the survey. So you can scan the QR code or the link will appear in the chat in the minute, and there will be follow-up emails, and it's going to be all available on our website as well. The survey will be open until the 31st of January 2026. If you have any questions, please do not hesitate to contact us. The survey should take you between 5 and 15 minutes. It's a big sample because it's a bit of a choose your own adventure. So depending on how many questions you're going to end up responding, it's going to be slightly longer. Everyone is accessing the survey through the same link. And then depending on your responses, you will have a set of different questions. Those questions are going to help us address some of those gaps that Portia has mentioned, the things we don't know and are going to be important for the cost modeling. So we're going to ask questions about to all stakeholders about depending on your consumer or health practitioner, are you currently using apps? Are you currently supporting consumers using apps? What are your views around the funding mechanisms? For health practitioners who are currently health practitioners, there will be a set of questions more specifically around how much time you spend or how much time you think you would spend, and what would be the work impact. And that will, again, help with the modeling down the track. I think that's it about that. We will put this slide back up if that's helpful later. In terms of the next steps, so as I said, the survey is open until the 31st of January. We plan on having a follow-up webinar where we're going to present the survey results. So around March, April, we don't have a date yet. And then the cost modeling analysis will happen in April, May, with the final report to the Department of Health in June. And again, that page, the link is in the chat around what the project and updates along the way. And we are running on time, so we've got time for questions. So put your questions in the Q&A, and we are going to have a look now. Okay, Laura is sending us in the separate chat. I can answer this one. Does this project respond to a small component within a broader review of funding mechanisms in primary care? So yes and no. In terms of this project specifically, AIDH and CDTH, we are only looking at this aspect. Now, I'd like to acknowledge the broader policy and advocacy context where plenty of other people are conducting some work around this topic. There are references in the report, but as Portia mentioned, the Productivity Commission has definitely been looking into it. Some other peak bodies have worked into it, and IACPA has worked into it. So there are plenty of different pieces of work happening at the moment to look at funding mechanisms to support digital health. And yes, it will require much larger investment in research, as Portia just mentioned. There is an evidence gap, and it's not specific to this work. It links to the evidence gap on long-term prevention. on the framework. I'm curious about consumer involvement in this research up until now. Has it built on the previous work on the framework? So there, yes and no. This project definitely is in the continuation of the work done before on the framework, but it's also a distinct piece of work. So we've kind of did a restart on the 1st of July, sorry. So in terms of the detail of consumer involvement, to be honest, I wasn't at inception of the other project, so I would have to go back, and I'm happy to go back and look into it and come back to you. Right now we have the CDTH. We've chosen to work with CDTH for many reasons, and one of them is that they have a consumer representative on staff. We have a consumer representative on our advisory committee, and we have contacted a few organizations and a few people specifically for their as consumers or consumer representatives to contribute to the project. Motivating patients with money. Sorry. Do you have any ideas around using funding to motivate lifestyle changing behaviors amongst patients? I.e. thinking about funding not for healthcare providers, but motivations for patients. Well, I don't know about that. I don't know if money motivates people to change their behavior. I'm not a specialist in behavior change. But it's... in terms of this project and funding mechanism to enable adoption of preventative health apps, yes, we are not going to do the work, but yes, we certainly believe that it is important that they are funding to cover the cost to consumers of using those apps to allow for access. And again, those costs involve both the cost of the app itself, but also any costs linked to access to the internet or data and the devices themselves, smartphones, tablet, laptop, or the wearables. Plenty of apps work in conjunction with a watch like this one, or other kind of devices to take the measurements. All that needs to be covered.
I'll just add, I agree with everything Carol was saying, and I'll just add, it was although behavior modification we decided just to exclude it from our review because we just didn't have the resources to include everything. But there is a whole class of apps that are focused around behavior modification. And I think like a particularly promising area for that is in supporting people with substance use disorders. And I think that's like particularly high concern in Australia. So we didn't pull those articles, but we certainly encountered a lot of them. And I think it speaks to the necessity for something that the Healthcare Productivity Commission was very clear about, which is the necessity for a framework, because the existing frameworks for drugs and medical devices are very focused on reimbursing the healthcare system. But that doesn't mean that those are the only things that could be cost effective. And we just don't have a good system yet for deciding from a policy perspective what's worth funding. Doesn't mean the infrastructure shouldn't be created. And I also see there's a question about gaming theory. And I'll just read the question since I guess everybody can't see it. Are preventative health apps using game theory to change consumer behavior for improved self-management? Again, I think this really falls a little more, again, in the category of apps that are more consumer oriented and consumer focused and not necessarily clinician oriented. But I can say there definitely are a lot of them out there and a lot of folks leveraging those ideas to create useful apps.
Next question, will you also be conducting qualitative work with practitioners on what the work generated by different types of data feeds is? For example, feeds asynchronous with appointments which highlight the patient may be at risk will demand instant response, with the system in private clinics, for example, is not set up to do. So, well, one, that's definitely something to put in place. Like if it's an app that has the kind of alerts that require 24/7 monitoring, then it shouldn't be put in place in a place where they don't have 24/7 people on staff. So it definitely has to be part of the safeguard around that that funding, that obviously those alerts need to be able to go somewhere when they need to go somewhere. Yes, for sure.
Oh, yeah, no, I also wanted to just add, I think this is an important question, but either was, maybe reflecting the limits of our review, or maybe the limits of maybe what the scope of this funding should cover. We didn't actually see any interventions where clinicians were responding like 24/7 monitoring or responding in real time, right? So all of the interventions that we reviewed either had the usual model was something like data would be transmitted and then it would be reviewed, sort of the next business day by a nurse, or it would only be reviewed sort of periodically or passively. And so I think it's a really good point that there is a potential for the kind of system where someone might like the right response might be to call the patient and say, like, get thee to the ED now. But it also, like, it's important to recognize that maybe there is maybe there's existing things like virtual EDs, and maybe that it should be outside the scope of remote monitoring, although I think it's honestly up to the clinician about what they can or should handle. But that wasn't actually an aspect of the things that we saw in our review.
Thank you, Portia. So that's all the time we have for questions. We will review the questions that are unanswered if there are any still, and we will publish responses on our website. And maybe if we can put the slides with the QR code again, link to the survey. Thank you so much, everyone, for attending today. We are very looking forward to seeing your responses. Please do not hesitate to share the survey with your families and friends and colleagues. We are really looking forward to seeing the information coming from you, and we are looking forward to updating you on the next steps, for sure.
And I'm just so glad that we had a great audience here. And thank you for coming, and get in touch if you have questions or even just want to discuss your ideas.